Good afternoon. My name is Megan Coker, and we are going to use this lecture to provide a little bit of context prior to our educational event on breathing dysfunction and tensegrity. And so we're going to use this as an opportunity to revisit some of the foundational concepts around breathing pattern dysfunction. But I also want to talk a little bit about the autonomic nervous system and how it can relate very heavily within the context of tensegrity and evaluating and treating the nervous system with regards to rehab. So hopefully this is a nice refresher as well as provides a little bit of background information to what we will be doing. Goal for today obviously will be to describe the fundamental concepts and principles of autonomic nervous system dysregulation and breathing pattern disorders. So the autonomic nervous system is a branch of the nervous system responsible for automatic, involuntary regulation of organ and systematic functions such as heart rate, digestion, respiration, blood pressure, etc. We have typically learned about the autonomic nervous system within the concept of the sympathetic and parasympathetic branches. We have our rest and digest in the parasympathetic, and then we have our fight or flight with the sympathetic. And what I've really dug into over the past few years with the ANS is something called the polyvagal theory, which explains the role of the ANS within the context of psychology and treatment of different disorders and pathologies using a third branch called the dorsal vagus branch. And so essentially what we're looking at is we have our spinal sympathetic, which is our fight or flight. We have our parasympathetic, which is our rest and digest, and this third branch is considered to be freeze. And so we'll get into this a little bit further here. So this is going to be the big breakdown slide for the polyvagal theory, just to help provide a little bit of context. So polyvagal theory breaks down the branches of the autonomic nervous system, specifically from cranial nerve 10, the vagus nerve, into these three branches. We have our ventral vagus, which is our parasympathetic state, and this revolves around social engagement and feelings of safety. We have our spinal sympathetic branch, which is our fight or flight branch, mobilization with fear. And then lastly, we have the oldest and most reptilian branch of the dorsal vagus, which is considered to be immobilization with fear. So I'll kind of go through each of these together. Humans need to be able to fluctuate between these different states. So when we consider the rest and digest, which is our parasympathetic state, we think safety. When we are in a parasympathetic state, our system is in a space where we are able to relax and connect and feel very physically and emotionally safe. This is incredibly important within the context of injury recovery because when we are in a parasympathetic state, we are experiencing those feelings of safety, good health, community. We engage in self-soothing behaviors, and ideally, the ventral vagus, or this parasympathetic state, is one that we can want to easily return to kind of as our baseline. We also need to have, as humans, the ability to quickly react and divert into a sympathetic state, which is our fight or flight, because it allows for us to react quickly and efficiently to what our system perceives as threats or danger. So the polyvagal theory describes this term called neuroception, which is the way in which our autonomic system consistently scans and detects threats. And this concept of neuroception is very, very built upon the experiences that we have over the course of our life. So for example, if one time I burned my hand cooking eggs, I might have my system perceive cooking on a stove as a little bit more of a scary concept to someone who's never burned their hand cooking on a stove. And so the sympathetic system is really helpful because it allows us to react quickly, avoid danger. So if you think similar to how you feel when you step out into traffic and a car is coming faster than you expect, or you're playing a first-person shooter game and someone comes around the corner unexpectedly and shoots you, You get that shot of adrenaline, the heart rate increases, you might get a little sweaty. That is the sympathetic chain at work. And in an ideal world, once the perceived danger passes, we should be able to shift fairly easily between a sympathetic and a parasympathetic state. So we should be able to, danger is past, I can return to my rest and digest. Through the lens of clinical care, this can be really helpful because it allows for the perception of pain or knowing that something just isn't right, which are abilities that athletes lean on very heavily when they provide context during an injury evaluation. However, when the autonomic nervous system is overwhelmed, it can result in this kind of inability to shift easily between states, or someone can end up in this chronic state of sympathetic upregulation, and that's just not a great thing. I think we've kind of all been in this type of state at one point or another. It's a very familiar feeling for a lot of people, where, especially as athletic trainers, we're stuck in that go, go, go mode, and we never really get a chance to relax. And I think spring season is a great example because you are just getting stimulation from all sides. It's very hard to turn off. We're working long hours. Spring season, we know, is just a long grind. And so it's very easily it's easy for people to kind of get stuck in this chronic upregulation, super overstimulated, very easily stimulated. And this can become a problem, especially when people are stuck in a cycle of pain, fear, anxiety, especially for athletes if they're injured. And I think that's a really hugely important piece of clinical care that we could be navigating during an acute phase. So lastly, we have our third and, according to the polyvagal theory, most deep-rooted and reptilian response, which is freeze. So we know possums play dead when confronted with a danger. And basically what happens is this response occurs during traumatic events when the system overrides all sense and completely shuts down. So humans, sometimes in instances of severe trauma, can go into kind of this hard dissociative state that's difficult to come out of. And, within the context of injury, we're not, this could obviously happen during a very traumatic injury on the field or something like that, but we typically see this more as kind of a slow burning state when someone has been stuck in a sympathetic state for way too long and they just can't get out of it. And so psychologists describe ascending and descending through these autonomic states similar to how you'd come up and down a ladder. So if you start in a parasympathetic state, you can go down the rungs of the ladder to a sympathetic state, and then you should be able to come back up. But if you go down from a sympathetic state to a freeze state, it's harder to come back up. And so sometimes you can kind of get stuck, like I said, in that cyclical kind of upregulation. And you have to be able to kind of find rest with parasympathetic ideas with rehab and treatment. So generally what we see is when patients come in with kind of those complaints of helplessness or feeling apathetic, depression, dissociation, we have to focus on techniques to get them slowly back up the ladder by stimulating a parasympathetic response. So in summary, we want to think of trauma, especially within the context of injury, interrupts the process of building safety, and it really sidetracks our ability to regulate. And so we should be able to fluctuate pretty easily between states of stress and safety, but when the gas has been pressed down for too long, we burn out. And so positive experiences are really important to help regulate the autonomic nervous system. So this could be social connections, just plain rest, indulging in hobbies. And I would argue that this is really where disablement models come into play, because we need to be able to connect with a person outside of who they are as an athlete to really be able to help them through that trauma. Shifting a little bit more on the clinical side, especially with regards to autonomic nervous system dysfunction, we kind of look at this sympathetic upregulation as things that jump around. And so A lot of the times with dysregulated individuals, I'll kind of call it popcorn pain, super indicative of chronic dorsal activation, because essentially what you're doing is you have this person who comes in and they're hurting in a different spot every time, or they can't ever seem to stay healthy, or you're treating one symptom only to have something pop up somewhere else. And this can be really discouraging as clinicians because we're throwing the book at them when we're trying to make them better. But then they come in the next day with another issue. However, this type of presentation, if you know what to look for, may be very clinically useful in identifying and treating autonomic dysfunction. So, on the physical side, we might have symptoms that just jump around. Maybe they have pain in the knee one day and then shoulder the next, or they're having back pain, or, they're just having issues with just not feeling well. And then we look at this also within the context of emotional well-being. So how are their emotions? Are they irritable? Are they feeling down? Are they feeling anxious, depressed, difficulty sleeping, excessive worrying about the injury or anxiety about the injury? And then we can also have issues with relationships. If you remember that the parasympathetic is very dependent on positive experiences, social experiences. So people who are stuck in a chronic, upregulated, sympathetic, or dorsal freeze state typically will be a little bit withdrawn, and they're not engaging with their friends or family the way that they used to, and they kind of like to spend more time alone. Maybe they're indulging in habits that are unlike them, coping mechanisms like drinking or smoking, excessive use of medication, and just loss of interest in things that they normally like to do. And so all of these things, if you kind of put the pieces together and really know what to look for, can point towards autonomic nervous system dysfunction. And remember that there is a line between what we have the ability to diagnose and handle as athletic trainers, right? So if we are worried about someone that is really demonstrating signs of dysfunction and they're not responding to some basic techniques, it is worthwhile to have a conversation with that person or that person's family about looking into working with a psychiatrist or something like that. So what we want to do is really just kind of be on the lookout and be able to understand where these patterns come from. And a huge aspect of this kind of falls in within breathing pattern dysfunction. So we're going to kind of shift gears a little bit. BPDs are almost always associated with autonomic nervous system dysregulation. It is part of the clinical test, so this can be really helpful as well. So breathing pattern dysfunction, kind of going back to some key things here, we can identify as an alteration in normal biomechanical patterns of breathing that can result in intermittent or chronic symptoms that might be respiratory or non-respiratory in nature. Also defined as inappropriate breathing that is persistent enough to cause symptoms with no apparent or organic cause. And so BPDs are present in a variety of individuals, often with musculoskeletal dysfunction. And it can go by a lot of different names. So sometimes we refer to this as dysfunctional breathing. Sometimes it's a breathing pattern disorder or dysfunction. Sometimes not so much. This is a little outdated, but we could call it hyperventilation syndrome. So these types of things are kind of very vague, very across the board. And again, all the better to be able to recognize it and be able to attack it because it's super important. As I've said before, there's a lot of literature around breathing dysfunction, but it is not super well translated to a clinical context. And as of right now, we still don't really have a gold standard to diagnose a breathing pattern dysfunction. We are very heavily leaning into kind of a clinical battery of tests to help us find what level of dysfunction we have. So an estimated 50 to 80% of adults have some level of BPDs. This could be something that kind of comes and goes. It could be something that's a little bit more deep rooted. If they are kind of in that chronic sympathetic state, that breathing pattern dysfunction might be constantly present. And BPDs play a huge role in experiencing musculoskeletal pain, dysregulation, movement pattern dysfunction, and things like that. So we want to be able to look at this within the context of assessment and treatment because it is something that hits really, really hard and makes a big difference in clinical care. So going back a little bit to the physiology behind respiration, we know that breathing is going to involve intake of oxygen and exhalation of carbon dioxide. And dysfunctional breathing can result in kind of tipping the scales a little bit in either favor. And the body is going to compensate for those changes in pH by either increasing or decreasing respiration rate. So if we have rapid breathing, like a hyperventilation, we're going to end up with decreased CO2 levels, which is going to spike acidity in the body. And then more slow breathing, such as in a parasympathetic state, we're going to end up with increased CO2 levels, which is going to kind of neutralize everything. And because the drive to breathe is so heavily regulated by the autonomic nervous system, fluctuating between those states are going to drive the different concentrations of carbon dioxide in the bloodstream and can perpetuate issues with breathing pattern dysfunction. And so we see that individuals with breathing pattern disorders are going to tend to breathe in a manner and stuff very disconnected from respiratory and metabolic requirements. Quick review on the anatomy with regard to respiration. We can kind of break this down into the outer core and the inner core. So the muscles of the outer core are going to be primarily responsible for postural stability, external load resistance, movement production, transfer of rotational energy. So you've got the erector spinae in the back, intercostals, external obliques, rectus abdominis in the front. And then if we move more inward, we have the muscles that are very primarily responsible for respiration, but also have some sort of stability component, like the diaphragm, multifidi, transverse abdominis, and the pelvic floor. And these muscles are primarily responsible for respiration, continence, and segmental spinal stabilization. Quick review of the diaphragm. It is a primary muscle with regards to both spinal stability as well as respiration. And the diaphragm develops pretty early, contributes to a lot of motor learning processes as well as spinal stability, and it provides a large amount of inhalation force. So it's something that we really want to focus on both evaluating and treating. Respiratory mechanics are going to play a key role in posture and spinal stabilization. So literature has found of the 20 plus muscles that are associated with respiration, nearly all of them play a dual role with regards to postural and respiratory function. So for example, we have the diaphragm, which is considered to be a respiratory muscle, but due to its attachments has a high postural function. And then the abdominals are considered to be postural muscles, but they play a role in respiratory function. And so what we see during normal respiratory mechanics is as the diaphragm contracts during inhalation, intra-abdominal pressure is going to increase, and the pelvic floor is going to release and lengthen and move downwards. And we see a slight activation of the extensors in the head and the neck and the lumbar spine. And so ideally, with normal respiratory mechanics, what we'd like to see is kind of a nice 360-degree expansion through the abdominals and the lateral ribs. And as we exhale, then we start to see the abdomen become more rigid, able to transmit greater mechanical loads, lending stability to the spinal column, and the diaphragm is going to relax and move upward. The ribs and the sternum are going to move downward, and the abdominals and the pelvic floor are going to contract in order to move air out of the lungs. So breathing should ideally look like equal parts inhalation and exhalation with minimal excess effort seen through the abdominals or the scalene muscles. And we want to have as much synchronized activity of the upper and lower rib cage and associated muscles as we can get. When someone comes in with a breathing pattern dysfunction, we often want to attribute it to one of these three things, or it could be a combination of any of these three things. So biochemically speaking, we know that breathing is going to be mediated through autonomic and central nervous system responses. And so from a biochemical standpoint, we want to be looking at how dysfunction can be created or caused through an insufficient exchange of gases. So a situation where someone has increased CO2 could potentially trigger inhibition of the diaphragm and other postural muscles. Oftentimes, a biochemical response triggering a breathing pattern dysfunction is respiratory alkalosis. And someone who has chronic respiratory alkalosis may have altered electrolyte balance, decreased tissue oxygenation, and muscles affected in this way can really become more prone to fatigue, dysfunction, development of trigger points due to kind of that altered activation sequencing, and all things that we want to be able to consider. And I've mentioned this before with regards to respiratory alkalosis, but another fun fact is that women have a higher tendency towards respiratory alkalosis because they have a higher rate of respiration. And especially in the luteal phase, because of increased progesterone, women are more premeditated towards respiratory alkalosis. So also another question that we could potentially ask from a biochemical standpoint. Biomechanically speaking, and we'll get into this more with regards to tensegrity, we kind of lean into this concept of regional interdependence. And so if we have muscle imbalances, if we have pain or restriction or poor motor control, that can lead to altered motor control patterns and subsequent pain and dysfunction. And so biomechanics are a huge thing that we want to lean into. And we could potentially kind of ask ourselves, is this a chicken or the egg type situation? Is the breathing pattern disorder causing poor biomechanics? Or are poor biomechanics causing a breathing pattern disorder? And it's one of those things where we just have to evaluate and try doing different exercises and different tests to be able to see what changes. Lastly, we have our psychosocial aspect, and this is a lot more affiliated with the autonomic nervous system. So breathing is particularly sensitive to different states of hyperarousal. And so entering into a sympathetic state, whether it's due to emotional reactions, whether it's due to adrenaline, fear-based responses, can drive the accelerated heart rate and respiratory rate. And so someone who is either in a sympathetic upregulation state, or if they're experiencing trauma from injury, or even just experiencing pain from their injury, can drive further perpetuation of a breathing pattern disorder. And so I would say more than likely the psychosocial aspect, especially with regards to autonomic nervous system dysfunction, is something that we absolutely want to be kind of getting a handle on as we're treating this patient. We will get into this a little bit more during the lab portion, but just a quick reiteration of our types of breathing pattern dysfunctions. First, we have paradoxical, which is going to be the most severe. And in paradoxical breathing, the abdomen draws in upon inhalation due to inadequate tidal volume and overactivation of accessory breathing muscles. So we have a very insufficient exchange of gases, and it's considered to be the most severe breathing pattern because it often indicates significant respiratory muscle dysfunction or impending respiratory failure. And basically what we're looking at is in paradoxical breathing, it suggests that the diaphragm is no longer functioning properly and the accessory muscles are having to really overcompensate. We can also have a very severe paradoxical breathing called flail chest, which is where the chest actually dips in upon inhalation. Usually this is a subsequent to very severe trauma. So apical breathing is most common, and this is what we would consider to be kind of our chest breathing pattern, which indicates overactivation, overutilization of cervical musculature and the accessory breathing muscles. People who present apical breathing patterns are typically more prone to mouth breathing, and when you look at them, you see kind of a lifting motion rather than an expanding motion during inhalation. Hyperventilation is the rapid, deep breathing that's going to alter pH, potentially put someone into respiratory alkalosis. And remember, with respiratory alkalosis, that severe kind of inefficiency of gas exchange is just going to kind of further perpetuate altered mechanics. And this is going to usually occur in cases of anxiety or panic attacks, asthma attacks, things like that. And then our last category here is restricted. And this is kind of more of an umbrella term, but we will look at what muscle imbalances, weaknesses are present that are restricting breathing in certain positions. Patients might have pain or restriction in certain positions. Those altered mechanics may further drive pain and dysfunction, so something to just kind of be aware of on the evaluation. So key takeaways here, the autonomic nervous system dysfunction is something that we really want to lean into and consider when evaluating and treating patients, especially when they display anxious, depressive tendencies, malingering pain, or pain that's just chronic and not getting better. There exists a lot of treatment options for clinicians to really work on increasing vagal tone and regulate ANS functioning. So it is very simple to do that, as well as simple and effective to evaluate and treat breathing pattern disorders. So we have to remember that BPDs are often very intimately linked with ANS function, and it's often worth treating them to kind of determine the next steps. So during our lab, we will kind of integrate these concepts, especially within the concept of tensegrity. So hopefully this was a helpful overview, and we will touch base during the educational event.